Today we will discuss about meniscus, the normal knee biomechanics, an important aspect of the anatomy of the femoral condyle, tibial condyles, and concept of screw home mechanics. Now, concentrating at meniscus. Meniscus is basically crescent-shaped fibrocartilaginous structures function to deepen the articular surface and aid to disperse load across the knee joint and acts as a secondary stabilizer. They are composed of type 1 collagen. The medial meniscus is a C-shaped and peripheral 20 to 30% is vascularized. It has more soft tissue attachment and is less mobile than the lateral meniscus. Regarding the lateral meniscus, it is more circular, less soft tissue attachment, has a popliteal hiatus, which is an important concept and can be tested by arthroscopy images, and is more mobile, with twice excursion when compared to the medial meniscus. 10 to 25% of the lateral meniscus is vascularized. So basically, outer 1/3 of both menisci are vascular and has a good healing potential. Regarding the normal biomechanical concepts of the knee, if you notice, the lateral femoral condyle is longer in AP diameter and straighter when compared to the medial femoral condyle. The lateral surface of the lateral femoral condyle is tilted 10 degree, while medial side is tilted 25 degree. This is important when fixing distal femoral fractures and measuring the screw length or a position of the plate. During plate fixation lateral aspect of the femur, the X-ray or the C-arm beam needs to be internal rotated, or the leg has to be external rotated to 10 degree to get a perpendicular view. If you want to see the medial aspect of the distal femoral surface, to check the screw length, the leg needs to be either internal rotated or external rotated to about 25 degrees. Also remember, the lateral femoral condyle, the lateral aspect is straight while and is longer, while the medial aspect is short and oblique. Regarding the tibial plateau, the medial tibial plateau is concave, which contributes to its lack of translation when compared to the convex lateral tibial plateau surface. Regarding the movements in flexion extension of the knee, there is a rolling and translation on the tibial plateau. On the knee extension, the center of rotation translates anteriorly, while in flexion, the center of rotation goes posteriorly and also pivots around the medial side. The lateral side, due to its long and straight condyles, convex surface, and lateral meniscus, has twice the excursion or translation, begin to translate posteriorly across the surface of the tibia. This causes relative internal rotation of the tibia on the femur during flexion of the knee. This motion is reversed in extension of the knee. So in extension again, it pivots around the shorter, more oblique medial femoral condyle and concave tibial plateau, while long straight lateral femoral condyle raises forward and convex lateral tibial plateau, and the lateral meniscus translates anteriorly. This causes relative external rotation of the tibia in relation to the femur in extension. So this motion at extension is called screw home mechanics. At extension, there is 10 degree external rotation, and at flexion, there is 10 degree of internal rotation. This last 20 degrees of extension is essential to lock the knee. The popliteus, which wraps around at the insertion of the lateral femoral condyle to the posterior tibia, is an internal rotator of the tibia. It fires on initiation of flexion, internally rotates the tibia, thereby unlocking the knee joint. So popliteus itself has an effect on unlocking the knee joint. When we see the lateral projection of the distal femur, The lateral femoral condyle appears more anterior and proximal. This can be remembered by LAP, L-A-P, LAP. Lateral femoral condyle appears more anterior and posterior. And similarly, the medial femoral condyle is more posterior and distal. This is a very important concept while doing DCS or distal femur fractures. Regarding the tibial plateau, the medial tibial plateau is concave, while the lateral tibial plateau is convex. And the tibial surface, when compared to the tibial shaft, has a 3 degree of varus. So its in extension makes sense that the medial femoral condyle, it needs to be distal, and inflection needs to be more distal in order to stay congruent relative to the lower medial tibial plateau. Now regarding patello-femoral joint, patella articulates with femoral trochlea. The patella itself has a medial lateral facets. Patella withstands incredible amount of forces, approximately 7 times of the body weight while they squat, or 2 to 3 times the body weight when descending stairs. It is the thickest articular cartilage. Whenever shown a sunrise view, the most prominent part is the lateral side. Regarding the Q angle, due to the Q angle, the patella has a propensity to sublux laterally, and that's why lateral femoral condyle is more prominent. The past 30 degree of flexion, the main stabilizer is bony constraints, that is lateral femoral condyle. But in extension to 30 degree, the most important constraint for the stability of the patella is medial patello-femoral ligament. It runs anterior and distal to the adductor tubercle just above superficial MCL insertion to the supermedial border of the patella at the junction of proximal and middle third. The effect of loss of medial patello-femoral ligament can be tested by a J sign, where patella subluxes laterally at the terminal 30 degree of extension.